Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Welcome, and thanks for joining the 47th episode of Conversations with CEI. My name is Lauren Walker, and I'm the Program Director for CEI's Hepatitis C and Drug User Health Center of Excellence. Today, we'll be talking about the 2025 annual New York State Hepatitis C and Drug User Health Conference. On September 9th, we hosted our first in-person conference dedicated to hepatitis C and drug user health. A group of New York State-based clinicians met in Catskill for a full-day agenda focused on integrating wellness into clinical practice as a way to improve patient care and outcomes, as well as innovative decision-making frameworks to help clinicians navigate complex scenarios in the absence of strong formal evidence, like clinical guidelines or peer-reviewed studies. Today, we'll be hearing from conference planner and facilitator Taylor Edelmann, an educator and consultant working at the intersection of LGBTQIA+ health, drug user health, and harm reduction. He'll be sharing his experience and insights about the day. Taylor currently oversees the Lighthouse Learning Collective at the National Harm Reduction Coalition, a program focused on supporting LGBTQIA+ harm reductionists and people who use drugs and engage in sex work. Taylor, thanks again for joining me today. How is your day going?
Thanks for having me, Lauren. It's good to see you again or hear you again. Just another day as a harm reductionist, as a public health consultant, trying to do the work as best as I can or as we can.
We are appreciative of you and the others like you who are out there. I can only imagine what your work is looking like these days. So, Taylor, I'm curious. I just want to start with an easy question. What were some of your initial reactions or your general thoughts about attending and participating in the conference?
Oh, yeah. So overall, I was super excited when you all reached out, asked me to help facilitate and help plan. Although I come from the world of harm reduction and HIV, Ryan White care, I'm used to attending harm reduction focused conferences, right? There's so few of them. So it was really exciting to see that one was not only focused on drug user health, but also Hep C. Because as I'm sure probably a lot of the providers or people listening to this know, Hep C is not seen as something that's as important or as deleterious to someone's health, because a lot of times people feel fine, they don't have any symptoms. There's really wonderful treatment now with really high cure rates. So I think all of that fits into that area. I was also super excited to join because I love working with providers. And as someone who has flirted with the idea in the past of going to med school about 8-9 years ago, I find that there's really such a nice variety in different areas of practice and different specialties. I've definitely been known to upset maybe a few of them along the way because of the facilitation, maybe style or training, and reminding providers that you took a Hippocratic oath. And I think we'll talk about this probably in a little bit, but within addiction medicine in our field, it can definitely turn off or rub people the wrong way. So I think addiction medicine providers and people doing this work are some of the most steadfast and just some of the most brilliant and dedicated.
I definitely had that feeling at the conference as well. A bit of an outsider as a non-clinician, but it really does warm my heart to see groups of physicians and other providers speaking about the people that they work with as whole people. And the compassion and the passion that was in the room was very, to myself at least, very moving.
Absolutely. One of the things I noticed is that a lot of folks in my group, because we had been broken up into several groups, I was paired with Lauren Kelly, who's an amazing gerontologist, pain medicine provider at Mount Sinai. A lot of the folks in the group, and also in chatting with them at lunch or just little side conversations, they talked about how they feel really isolated, right? Especially our rural providers where access is really scant. They talk about how their colleagues view them almost as charitable for the populations that they serve and the work they do, which is obviously incredibly patronizing, is disrespectful for more reasons than one, right? Because that's also going to show up in patient care and how they're interfacing with their patients. And then providers or public health folks wonder why people who use drugs don't trust medical providers. So that was a super interesting thing. And I think goes back to just how dedicated a lot of folks are. I think what was also really interesting was to see that there was a large majority of the people attending were primary care or addiction medicine specialists. And there were so few folks, I think, that were in specialties or maybe subspecialties. And that's definitely an area where I'm probably getting ahead of myself, where I can see so much growth. And I think I was actually seated next to one woman who is an OBGYN, and she was fiercely taking notes, and she's like, I want to learn more about this. There's just not enough information when it comes to pregnant people who use drugs. And we all know that pregnant people who use drugs are treated extremely harshly. A lot of times their children are taken away from them, which we know has really negative impacts on just family systems, and also really drives up overdose rates as well. So I just saw so much potential, I think. And I think part of it too, what it comes back to for me is a lot of times I am in non-provider spaces, and I think about the way that sometimes I'll have to code switch when I'm in conversations with people, depending on who the room is, because it's maybe not safe or comfortable to talk about the things that I do. And I'll say public health consultant or just like public health educator, right? If you catch my drift. And I think a lot of times us doing this work, or even people who use drugs in general, we think that we are holding the stigma alone. And I don't think I connected or maybe realized how much of that stigma providers are also holding, and the ways that it shows up. Because again, going back to the folks that I talked to, and this was more than a handful of people, mind you, out of the 50 some odd providers that were there, they said even going to conferences and they bring up their specialty and what they do, providers sometimes will just walk away, raise eyebrows, or just not really be interested, and just say, oh, well, someone's got to take care of those people, quote unquote. So yeah, not great, not making people want to share or talk about their experiences, which we know has really adverse impacts on things, not only like overdose rates, but access to things like MOUD, right? Access to Hep C treatment and care, catching really complicated disease states before they get out of control, and then somebody is losing a limb or they're unfortunately passing away. So that's what it all circles back to me, but it was really great to be able to have those kinds of conversations with the providers.
Yeah, just a reminder to whoever is out there listening to us that, quote unquote, those people are all people. And we all deserve a space to have health, to have a clinician who cares for us. I'm curious, did you learn anything? I know you already touched on this, but interesting, worth sharing about the perspective of clinical providers who are working in this space. Did you see any of them coming to the same understanding about their role beyond just the doctor?
Yeah, I think one of my favorite parts, and I'm probably biased because I help plan and facilitate the session, was the wellness portion in the morning. So I could tell at first, it was a 90-minute session, mind you, and we had probably 9 or 10 folks in our group. And you could tell in the beginning, there was a little bit, I don't want to say like a hesitancy, but almost like a sheepishness of not wanting to really go all in on what we're feeling and what we're emoting. And I think some of that has to do with providers not even knowing how to process how they're feeling, because it's just expected of them. One of the things that Lauren and I did is when we opened up the session, I had folks take a sticky note and they doubled it up. So they wrote it on 2 stickies. One of them they put on their name tag. The other one they put on this piece of chart paper we had, and it said, "My strength during a crisis is." And what was really interesting is I think at least 2 or 3 of them said not showing emotion or not crying, which is so vastly different than when I do this exercise with frontline staff, right? Or community members, and they talk about things like maintaining my calm and being able to get help when I need it, and so on and so forth. There were 1 or 2 people who said they remain calm, but it was interesting to see. You could almost see the burden or kind of the responsibility they put on their shoulders. And that has a huge impact on the way that they show up and work with their colleagues and also with their patients. So in breaking that down, what we did is we got them to go outside because we're all in a shared space. We wanted people to get out. And what we did is split them up into different stations. We had them practicing breathing techniques, embodiment practices, just things that were really practical that they can do in between changing shifts, going home. I know a big thing for a few of the providers was saying it's difficult sometimes to switch over from like provider Sarah to mom Sarah, and how I show up at home and not take this, as I call it, emotional residue with me back home. How do I stop it, or how do I mitigate it so it's not showing up in ways that are impacting my home life, because that balance is so important. And what was amazing about that as well is that Lauren actually did this whole narrative medicine piece, which if you're not familiar with that, turns out you can get a degree with it. degree in it, which is amazing. And you should check it out. But basically, it's a way for providers to interface with poems and writings and different teachings and materials to really be more compassionate, not only to themselves, but to the people that they're serving. So that was just a really special kind of session. And I think a lot of providers want to discuss cases. They want to really chop it up and get into the nitty gritty about really complicated cases and things that they're experiencing. But I think a lot of them saw the inherent value in slowing down, taking a pause, because they typically don't get that time, right? To just connect with one another and say, hey, you know what, I'm in the city and you're all the way up in Rochester, and we have a lot of commonalities, right? Because we know, and I think I talked about this a little earlier, how isolating it can be in these rural areas where you're maybe the only provider in like a 50-mile radius, right? And just the toll that takes. So I think that was just incredible to witness in real time.
I love hearing that. And we very purposefully planned this conference to have a morning session and an afternoon session. So the morning session really focused on this wellness. And initially, we did just want to provide a space for people to focus on self-care and kind of experience what that's like. And I loved to see it grow into something where people realize the importance of this, not only for their own benefit, but as a way to actually improve the care that they're providing to the people that they're working with. So not holding on to some of those stronger emotions, feelings, some of the weight and the secondary trauma that comes with it, and being able to let go of that, start fresh, and come to the space with the full you as a clinical provider for the person who's coming to seek care. I think we've already covered the interesting challenges that clinicians face, but I'd love to switch gears and see if you have any recommendations or if anything came up as you experienced this of, what can we do? We live in this space where sometimes you are the only provider in a 50-mile radius, or you do experience stigma and work with other clinicians who maybe don't want to have any space in addiction medicine or working with people impacted by Hep C. What can we do? Big question.
Yeah, I know. Loaded question. And I'm not saying I have all the answers. I don't think any of us do. But I think one thing that was pretty apparent during the closing was a lot of providers had a hunger for maintaining those connections, right? They said, this day is great and we're in person, but we don't always have this time. And how do we maintain this level of connectedness outside? And I know you all at CI are probably scheming things and ways to do more cohorts and lunch and learns, but I think that is so crucial. Because again, isolation, we know, is not only a major driver for things like overdose for the people that we serve, but also for providers. It takes a huge toll, and then it really hurls them toward the proverbial wall of burnout, which is what we were trying to tackle in the wellness session. The other thing, though, that I kept thinking about, and this is something I always share in my trainings, and this is really important for providers to understand, and shout out to those that already do, is that people have different relationships to different substances, right? One thing I didn't talk about was the really interesting conversation about benzos that happened during the panel, the Q&A portion of the panel discussion. One of the providers talked about how a lot of patients view them as a quote unquote security blanket, which is why it's really difficult for folks to taper or to even begin to entertain the idea about tapering or coming off at some point. And I see this come up with it in folks who are very recovery or abstinence focused or based, where they don't even consider those on bute or methadone, right, on MOUD to be abstaining from use. Or I also think about it in the lens of, I have friends who have some really good experiences with drugs like meth or crack, but they later dipped into some chaotic use. They wanted to change that relationship. Maybe they want to still drink alcohol. Maybe they still want to smoke weed. Just really drilling down to this point that we can't paint every drug or every person with a broad brush. And just to tie this all up, one way that this really came through for me was a few years ago in my work. I did a qualitative study, a very small cohort of about a dozen or so folks, queer and trans people who use drugs and engage in sex work. And we had talked to them about their use and their relationship to use. And the vast majority of them said they would like to change their relationship to use, but they didn't want to stop using. Right. And I think it was the way that we framed questions and left a lot of space open for interpretation. But I think that goes against the grain where a lot of folks say, okay, like we're seeing now happen in real time, right? This push for abstinence and recovery, and that we need to work towards not using any substance, and we need to put people in treatment involuntarily and all of these things where that's not what people want, right? Drugs, substances serve many purposes for many people, and they have different relationships, or people have different relationships to them based on where they are at any given point in time, what kind of relationships, familial, friend-wise, work-wise, school-wise, whatever they have going on. So we need to be really mindful of that when we are doing intakes, when we're just speaking with them about use, because I think that'll really help people open up and be able to speak with their provider about, I never felt like this before. How come when I'm doing fentanyl now and I'm smoking fentanyl, I feel some type of way, but I didn't feel that before, where I used it for pain. I like the high that I was getting. And then providers can maybe talk about things like drug setting, right? The framework created by Norman Zinberg, and break it down in a way that's really digestible for people. We don't have to gatekeep all this information, I believe. And I think a lot of the providers believe should be freely accessible to everybody who needs it, because it could potentially save lives. So I love that.
Makes me think we had one speaker interactively ask the entire audience, raise your hand if you have ever lied to your doctor. And it took a few seconds. No one wanted to admit it. And 5 seconds later, every hand was in the room. And so another one of our facilitators, I think she had a wonderful recommendation, Dr. Kelly Ramsey, that it takes time. You cannot expect someone to trust you fully to be honest about something that is so shameful potentially, so stigmatized potentially, and just lay it all out there. You need to take the time to know people, to know what they mean when they say this is supporting me, this is doing something for me, so that you can understand this is a security blanket, but isn't something that's going to be helpful if I just rip it away from you right away.
Yeah. And I love that. I know, I agree that most people want a quick fix, right? And I think that goes back to, you probably remember this early on when we were planning the conference, I made a point to say, I love y'all providers, but a lot of times we're solution focused, right? We just have this narrow mindset of, we want to find the perfect kind of therapeutic mix. We want to solve the thing. We want this person to get better, and so on and so forth. But we often lose sight of that journey, not to sound all like foo-foo here, but we lose sight of that path it takes to get there. And really what that path is speaking to is what Kelly was talking about, what was Mary talking about as well, is creating that sense of trust and security with that provider. Because it is a very odd thing to walk in and just assume that because you have a white coat on, you have all these years of schooling and experience in your head, that's going to translate into a good patient interaction, when there's just been such a failure, I think, in so many ways, more ways than one, from just the medical industrial complex, right? So it does truly take time. And when you let your guard down and when you can really humanize the interaction, that's when you're going to have more of a breakthrough, right? It's not to say it's going to work, for every single person, every single time, right? But for the vast majority of people who are feeling very siloed, who are feeling isolated, you are going to create something truly beautiful.
Call to action to all of our listeners. Take the time, create something beautiful with the people that you serve. Taylor, I want to extremely switch gears here. And this is a non-planned question, but I'm curious, how was this training experience different from others that you personally have facilitated? I know you said earlier, you don't typically work with medical providers all of the time. So just wondering what the main difference is that you experienced.
Yeah, that's a great question. And totally fine. It's not pre-planned. I love going off the cuff. So I think I mentioned in the beginning that I'm not a doctor. I'm not a medical provider. Although I do train a lot of medical providers, the majority of the time, it's usually frontline staff, so medical case managers, therapists, or substance use counselors, harm reduction specialists. So people who are maybe new to the work, maybe people who have been around the work for a very long time, even before harm reduction was called harm reduction or what it is. And typically I don't have as much time with people. So this was a really nice opportunity to see the whole life of the project. I mean, I do wish we had more time with people. And I think that was well known by the end, right? There's certain capacity, funding constraints, all that kind of stuff. But I think there's a lot of potential to grow it. The biggest thing was being able to be a lot more interactive with people in the sense that I could take them from one setting to a next and do really in-depth. I could do the stations with people. Typically, I only have maybe an hour, 90 minutes, or 2 hours to get through an entire training, whether it's like an MLUD 101, a harm reduction 101, any kind of LGBTQIA focused training that we do. And it makes it very difficult because there's so much information to get through. So you have to balance pretty expertly how to interact with people and maintain the engagements, but still get all the objectives through that you need to. And unfortunately, a lot of times programs are deliverable focused, right? Where they need a certain training to get done. So sometimes you can see that people were maybe forced to be there. And I think the big thing with this is that this was a situation where you had people applying to want to be there. So they were highly motivated, highly engaged. And this is in no way to shade any of the folks that I train. I think it's also a testament to sometimes how burned out we are, especially with virtual or Zoom trainings, which is why I love doing in-person trainings where people don't want to sit there and listen to someone drone on and on. I mean, there are definitely tricks and tools in my bag that I have to make it more interactive, but I think those were some of the biggest takeaways that I had. Also, having an entire portion dedicated to clinical case studies. I think that's something we typically don't do in training because, again, I myself am not a provider. So that was a huge bonus of having a co-facilitator who was a provider to be able to lean on that, which was really invaluable. So it's truly a unique and special experience. And I guess this is also a part where I could plug myself and talk about how any of this sounds interesting. If you feel like what I'm talking about, what I'm putting down, I do this work for a living. So I facilitate, I love facilitating groups. I like establishing connection or kind of talking about points of tension, not only with providers, but really any group, any organization, any coalition that's looking to deepen their practice around harm reduction, around public health. I definitely have much more of a specialty in LGBTQIA health. Yeah, and just facilitating and training. So a lot of capacity building, a lot of organizational development and technical assistance. But it was really a dream scenario to be able to be part of this conference and be part of it from inception to the debrief that's forthcoming. So yeah, just truly grateful to have been there.
I think like you made it part of what it was too. So thanks are due there as well, just helping us from day one and being open and honest with what we should be doing, what was missing. And I kind of want to just bolster your self-plug if I can, that everybody needs this. If you're out there listening to us thinking, nope, that's not for me, I am not picking up what you're putting down, I would encourage you to check out CEI and check out Taylor even more. I learned a lot about harm reduction, about working with people who use drugs. And I was simply logistic facilitator on the offsides, and I do this every day. So I think it is really important, and to bring us full circle to the beginning of the conversation, that there are a lot of providers out there who don't do this work. I'm not trying to judge you or to place anything out there, but that I think is a safe fact to make on this podcast. And I think it's also safe to say that a lot more people could be doing this work. It did warm my heart to see a few outliers come in, but in a perfect world, I think there should be hepatitis C screening and treatment in every drug treatment program. I think that every OBGYN can and should be testing for hepatitis C. They should be screening for substance use among people who are pregnant, and they should be providing that ongoing support. It sounds very simple, but obviously it's not, and this is Lauren's perfect world, but I think it's doable. And if people are listening and thinking they might be able to do it, or on the opposite side of the fence that I absolutely can't do that, I dare you to. Come see what it's like. We're here to help.
And I think just going off of that, I kept thinking about how cool it would be to see cardiologists there, pulmonologists there, neurologists there, because I'm sure many of you know this, when somebody overdoses or deprived of oxygen, what is that impacting, right? Like I have friends who have overdosed time and time again, and they have TBIs, right? And how do they interface or talk to their neurologist about this? Are they going to say, well, you shouldn't have used that. That was dumb. Why'd that happen? You need naloxone. You need all these things. That's not helpful. Or when I'm talking about cardiologists, if you're like, I don't get it. Think about the toll that stimulants can take on someone's cardiovascular system. Think about the adulterants that are in our drug supply right now. One of them coming to mind that I know has an impact on the cardiovascular system is medetomidine, which is showing up a lot in our fentanyl samples, right? And then in pulmonology, very obviously, what's getting impact? A lot of these drugs are depressing your respiratory system. Drugs like xylazine, which is a veterinary tranquilizer, that's a sedative. It's having an impact on your respiratory system. So just some kind of little pearls. If you're listening to this and you're like, I don't really see the connection, there is a connection point for you there. It's the onus isn't only on addiction medicine providers, on infectious disease providers, and on primary care providers who are already holding so much. It's truly a shared responsibility.
I love that. That's like our fourth call to action. So hopefully people are feeling very capacitated today while listening. I feel like we're wrapping up here. So I just want to give you space if there's anything else that you would like to share about our audience, particular to your experience with the conference, working with CEI, or just in the space of harm reduction and drug user health.
Yeah, I think biggest thing is I was just thinking, as someone who I live in Connecticut, but I do the vast majority of my work in New York, was why can't we have CEI, or why can't we have a conference like this everywhere? I actually, after I was talking to a few of my colleagues who are medical providers, and I was like, I just went to this amazing thing. I was able to facilitate, and they were like, how do we get in contact? How do we start something like this? So I think it just gave me so much to chew on and go on to be able to try to connect the dots here and just expand the work, because we know that a lot of times we're working with transient populations, right? They're crossing state borders. It's not like someone stops using drugs the moment that they leave New York and go into Connecticut, New Jersey, Mass, whatever the case is. So I think you all are you're vanguarding this whole process. I think you're doing brilliant work. And my hope is just that it keeps growing. You keep getting funded to do this, and that you're exciting more providers to be part of this work. And also people who are non-medical providers like myself, who, it can seem daunting to go into a space where people have tons of acronyms and degrees. And that very much, I have to say, was not the case, where everybody was extremely down to earth. They were very interested what I had to say. And I was also able to foster a lot of connections for facilitation and training with many of the providers. One was working on Rikers, one is working upstate, one is the head of a training facility, because there's just such a hunger, I think, for this work. So truly appreciated to you all for putting on such a special and bespoke event. It was really amazing.
Thank you for saying that. I will never get tired of hearing people's responses, particularly when they are so positive. But it was a true honor. Listeners, this was our first in-person conference, so we're all quite proud of the work that we did. And Taylor, just thank you for making it such a special day. It would not have been the same without you.
Thank you. Yeah, looking forward to the next one.
Yes. And thank you again for joining Conversations with CEI. It's been a pleasure chatting with you today.
Thanks for having me.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.